Okay, in this module we're going to go over visual tracking, cardinal fields of gaze. So what does it mean when we have the patient follow our fingers and track it? So very simple test. It's going to tell us a lot about their cranial nerves, their brainstem, their cerebellum, their general brain function. It takes a few seconds to do and can be very useful if you know what you're looking for. So we'll run through the test and then we'll do some discussions of how to interpret all these things, and hopefully it'll be a tool that you use and get a lot of information out of in your regular physical examinations. Okay, so we're doing cardinal fields of test. You can either use your finger or you can use something to look at. Here I'm using just a pinwheel. I'm just using the green area. You want to let the patient know to blink whenever they need to blink. Just keep their head completely still and just track with their eyes. So you can either do an H pattern or you can do a cross pattern. I like to go horizontally first. Just check horizontal. And then I like to do the obliques. That's one way to do it. And then you can also just go ahead and relax your eyes. And the other one is just the H pattern. You just go up here, have the eyes out to one side. Okay, now go ahead and relax. Let's actually take a look here. So if we just have her track right and left, we can see her movements are good. Right at the very end, you see a little bit of a... Sometimes it looks like nystagmus, their eyes are catching up. It's just they're not focusing on the target. You got to be very careful. Go ahead and relax your eyes. Whenever you see their eyes start to tear, let them take a break and just relax. So just even close their eyes. Let's go back and check these horizontal ones again. So those are nice and smooth. And then we'll check the oblique planes. And then just relax. And you can see that these are conjugate symmetrical movements on all sides. Total normal exam there. Great. Right, so when you're doing this visual tracking, these cardinal fields of gaze movements, you're checking several things. First thing you're checking is just general cranial nerve function. And with cranial nerves, we mean the nuclei to the cranial nerve and then the muscles that are innervated with the cranial nerves. So just remember that all eye movements are generated by cranial nerve 3, the oculomotor nerve, except lateral eye gaze, which is lateral rectus, the abducens nerve, and any movement down and out is the superior oblique muscle associated with the trochlear nuclei. Everything else is cranial nerve 3. So, just really simply as you have a person go back and forth, so this right hand going out is cranial nerve 6, this one is always cranial nerve 3, lateral rectus, medial rectus, and then it switches, medial rectus, cranial nerve 3, lateral rectus 6. And then anything up is all cranial nerve 3. These are all superior rectus muscles. Anything straight down is a combination. It's inferior rectus muscle. Those are all cranial nerve 3. But when you go on an oblique downwards, the eye that's going down and in is the innervated by the trochlear nerve superior oblique muscle, and the one that's going out is lateral rectus. So those are the basic concepts that you want to remember about eye movements. So if you have any kind of pathology, any kind of demyelination, any kind of macrovascular disease, you may see some weaknesses in those eye movements. The key thing with weakness is when they're doing this, you may even have a patient see double. So one of the things you also want to ask as you're going through these is, let me know if you ever see two visions, a superimposed image of each other. And usually it'll be at the end range. And sometimes when people have hyperthyroidism and they have that proptosis, or if they have any kind of tumors pushing their eyes out and there's misalignment of the eye muscles, when they look at areas, they can also see a double image. Now, if you ever see a double image, if a patient ever sees a double image with only one eye, then they know there's something wrong with the eye itself. If there's a double image when they're looking with both eyes, then the eyes are not having conjugate movement, and there's something wrong with their neuron-motor integration. Now, the thing you want to do is when you're looking at these eye movements, is as you're going through, you're first looking at the cranial nerves. So anything lateral is 6, anything down and in is going to be cranial nerve 4. Everything else is really related to cranial nerve 3. So that's one thing. The other thing you want to look for smoothness. Now sometimes you see something what's called like a saccade at the end, like end gaze, nystagmus. End gaze nystagmus. So as they look to the side here, you'll see a couple of beats. Those are always indication of cerebellar disease. And if you're working with people that have celiac disease, people that have had brain injuries, cerebellar injury, sometimes they'll get these gaze-evoked nystagmus. Nystagmus is characterized by a slow and a fast face. So they look in one gaze, and they start beating. It can be upward, it can be downward, it could be at any angle. So you always want to look at that. Now sometimes you'll have people that look like they're having gaze evoke nystagmus, they're just not paying attention on the target. So they're looking, it looks like it's bouncing, and then it's just because they're not paying attention. But with nystagmus, you get a couple beats, especially at the end, right? That's gaze evoke nystagmus. Sometimes you get someone who has an eye movement, and then you get a big movement inside of that tracking. It's called a saccadic intrusion, and those are happening with abnormal discharge of the brainstem. That'll happen with demyelination patterns. So when you're doing these simple gaze movements, and especially if you're working with patients that have autoimmunity and neurological autoimmune diseases like MS, like with patients that are older, elderly, that may have microvascular disease or hypertension, you're always worried about some kind of little injury or infarct in different areas of the brainstem centers, which you may find with these types of testing. Now, in addition to the brainstem areas where these cranial nerves are, the volitional ability to move the eyes in one direction is generated by the prefrontal cortex, the premotor strip. So if they just can't figure out how to move to one side, or they're having a hard time figuring out how to move to the left, move to the right, that's associated with a frontal lobe dysfunction, opposite of the side of their gaze that they're looking into. And it's just similar to dyspraxia. And then if you just see just not smooth movements, just kind of breaking down movements like that, it's associated with cerebellar disease. Those are non-smooth pursuits. The cerebellum calibrates movements. So if it's just moving jerkily, it's just something like finger to nose, or it's just bouncing around, it's not smooth. So when you look at the eyes, make sure there's normal tracking, everything's smooth, there's no end-stage nystagmus, there's no saccadic intrusions, and also that there's no indications of double vision when you're going through the test. And it's a very quick and effective way to rule out a lot of serious pathology.